Hello everybody, welcome to my channel. This is a pathology video on gastrointestinal pathology and the fourth in the series of videos on polyps of the intestine. It covers the topic classification and neoplastic polyps. This is by Dr. CSBR Prasad, Professor of Pathology, Sri Devarajaras Medical College.
And polyps of the GIT can be classified mainly into neoplastic and non-neoplastic polyps. And neoplastic polyps are equated with adenomas. So again, I stress adenomas of GIT requires a qualifier, that is dysplasia, whereas adenomas in other parts of the body will not have this rider. Okay, so if you want to call something adenoma in GIT, it must have dysplasia. Then non-neoplastic polyps can be due to inflammation, inflammatory polyp, hamartomatous polyp, or hyperplastic variety of polyps. Coming to neoplastic polyps of the GIT are known as adenomas. Adenoma, by definition, it is a benign neoplasm occurring in the glandular elements, and to call something as adenoma in GIT, it should have or exhibit definitely dysplastic changes. And colonic adenomas, I told you already, definition requires the presence of dysplasia, and they are small pedunculated polyps, or they can occur as large sessile polyps also. So the importance of this neoplastic polyps are they are precursors of colorectal adenocarcinomas. Clinical features: most of the adenomas are clinically silent, and large polyps may produce occult bleeding or even anemia, or there may be sometimes what is known as the fresh bleeding in the lower GIT. And villous adenomas may produce lots of mucus, and because of this loss of mucus, the patient may land in hypoproteinemia and hypokalemias. And these symptoms of hypoproteinemia mainly in the form of edema, or hypokalemia is mainly in the form of extreme weakness, will bring the patient to the clinic. So adenomas morphologically, size may vary from 0.3 to 10 centimeters in diameter. They may be pedunculated or sessile, and they will have velvety surface. And histologically, you will see dysplasia. That means hyperchromatic nuclei, stratification of the epithelium, and loss of mucin secretion or loss of goblet cells. And adenomas architecturally can be classified into tubular, villous, tubulovillous adenomas depending upon the appearance of this adenomas. So if the tubular adenomas are composed of small glands lined by cuboidal or columnar type of epithelium, which may show stratification and nuclear atopia in the form of hyperchromatism. Okay, and they are usually pedunculated variety polyps. So you can see that tubular adenomas, one is sessile, one is pedunculated. And histologically, you may see that pedunculated tubular adenoma, wherein the epithelium protrudes into the lumen over a stalk. And here you can see that whole polyp is composed of tubular structures lined by stratified columnar type of epithelium. And here notice the presence of atypicality on the right side. So it is a tubular adenoma with undergoing malignant transformation in the form of adenocarcinoma. And coming to second category, that is villous adenomas, they are often larger, they are single, and they are covered by slender villi. Okay, you can see that sessile adenomas, the villi-like projections can be appreciated in the cut surface of this adenoma. And this photography shows the surface of the villous adenoma, wherein you can see that finger-like projections. And the cross-section of villous adenoma or the external appearance sometimes may resemble shaggy rug. And histologically, we will see villi, various sizes protruding from the surface. And adenoma with intramucosal carcinoma. So you can see that adenoma showing hyperchromatic nuclei, and which is equated with the severe dysplasia. Okay. So it is probably the in situ variety of carcinomas. And Tubulovillous adenoma, they have mixture of tubular and villous elements, and this is the appearance of Tubulovillous adenoma. And you can see that it is not exactly resembling that of villous type of adenoma. And histologically, you will see villi and also tubular glands composing this polyp. And this is a villous adenoma, wherein on to the right, and to the right you are seeing the villous adenoma. On to the left, there is mucin secreting adenocarcinoma, which is arising from the villous adenoma. And lastly, the Sessile serrated adenomas. They overlap histologically with hyperplastic polyps. I told you the hyperplastic polyps show histologically serrations. But remember, these serrations are confined to the upper portions of the crypt, and the lower portions are spared. Whereas in the case of Sessile serrated adenomas, you will see entire crypt length is involved in this process of serrations. And this has got a very high malignant potential, and they don't show dysplasia. That's another feature of Sessile serrated adenomas. So in the beginning, I told you adenoma in GIT by definition should have dysplasia. This Sessile serrated adenoma is the exception for this rule. Histologically, you will see entire length of the gland is serrated, and there is crypt distortion with a lateral growth resembling a boot, and hyperplastic polyps, I told you already, show only serrations on the top portions of the crypt. And here you can see the entire length of the crypt is showing serrations. And this is the gist of tubular, villous, and serrated adenomas. Tubular glands is the constituent of tubular adenomas, and villous architecture is the feature of villous adenomas, and serrated adenomas will show the serrations of the crypts. And in addition to that, all these adenomas may show dysplasia. And adenomas and risk of malignancy, and most of the colorectal adenomas are benign. Risk factor is dictated by number of adenomas. So more the number, chances of landing in carcinoma is high, and size is also very, very important. So size of adenoma, if it is less than 1 centimeter in diameter, usually it is benign. But adenomas measuring more than 4 centimeters in diameter may contain malignancy, and anything over 1 must be sampled adequately in order to detect the cancers at an early stage. High-grade dysplasia increases the risk of the adenocarcinomas in any polyps. Familial polyposis syndrome. So several syndromes characterized by the presence of colonic polyps with the increased risk of colonic cancers. So these are the familial polyposis syndrome with different genes involved in this process, and they are associated adenomas. So tubular, villous, and adenocarcinomas, Sessile serrated adenomas, and in this case, familial adenomatous polyposis or FAP syndrome, wherein APC gene mutation occurs, and also this sporadic colonic cancers, MSH2 and MLH1, that is, these are the genes DNA associated with DNA mismatch repair, and they may have the potential for the development of adenocarcinomas in the future. And in addition to that, there are many familial polyposis syndromes like familial adenomatous polyposis, and wherein DNA mismatch repair gene can be at fault, or in some of the hereditary non-polyposis colorectal cancers, again DNA mismatch repair gene involving some other target genes may be the culprits. So familial adenomatous polyposis is autosomal dominant disorder, manifests very early, and numerous colonic polyps. That is a very characteristic feature of this FAP syndrome. At least 100 polyps should be there in the GIT to qualify to call this as FAP syndrome. Polyps are morphologically similar to sporadic adenomas. So that means they will have what is known as the dysplastic features exhibited by them. And here you can see that surface of the luminal surface or mucosal surface of the intestine, which is a big polyp, and small, numerous polyps making the surface of the intestine appear as if it is studded with some nodules. And histologically, you will see the polyps occurring in greater number. The importance, if untreated, colorectal carcinomas occur in 100% of the cases and often before the age of 30 years. So, because of this definitive association of colorectal adenocarcinomas, some of the high-risk patients are subjected to total colectomy. So, prophylactic colectomy is a standard therapy for individuals carrying APC gene mutations. Colectomy and malignancy. One more important thing you should not forget is colectomy may cure the patient of future occurrence of adenocarcinomas of the colon, but it will not prevent the occurrence of malignancy in other sites of the body. Okay, so GI tract, or particularly in the ampulla of Vater region and also in the stomach. So it will not eliminate the possibility of occurrence of malignancy in these sites even after total colectomy. So variants of FAP syndrome, you should know, that is Gardner syndrome and Turcot syndrome. And components of Gardner syndrome is osteomas. And osteomas, especially involving the skull, and multiple intestinal polyposis gives or the components of this Gardner syndrome. In the case of Turcot syndrome, multiple polyposis plus the astrocytoma, especially involving cerebellum. And there is one more condition known as hereditary non-polyposis colorectal cancers, or HNPCC, which is equated with Lynch syndrome. And you'll see familial clustering of cancers at several sites in these families. So what are the sites for cancers? Colorectum at very young age, and stomach, small bowel, hepatobiliary system, and also endometrium, ovary, brain, skin, ureter. Anything can be a target for this development of cancers in HNPCC syndrome. And genetic defects involves DNA mismatch repair genes. There are such 5 mismatch repair genes. Among them, HNPCC involves most commonly MSH2 or MLH1 gene mutation.
Thanks for watching. Please subscribe by clicking the button subscribe.